Um, so, um, so here we go. So I'm going to start the first, but everybody will be mad by the first couple of slides. So that's my full intent. You won't sleep. You may not like it, but you won't sleep. So ventilation really matters. And this table over here is going to feel really good for a while. And in fact, its importance is so profound that this is actually how the ABCs should look. You know, your classic concept of the ABCs, mine, it's all wrong. It actually should be, this is almost an afterthought. And it's all about the breathing. And as you're going to see, the breathing has an unbelievable impact on the circulation. In our setting, not doing it right, almost all negative. Okay, why? The three bad players, some of this is going to be new information for some of you. These are all bad players. Positive pressure ventilation, more detail in a minute. Hyperventilation, meaning breathing too fast, and overventilation. And we'll go into the difference between hyper and overventilation in a minute. And all of these, notice, as soon as you put a tube in, you now can drive a truck through that tube. So all three of these really bad players become really easy to do once you think you've saved a life by putting a tube through the cords. So here's the three bad players. Positive pressure ventilation is really bad for sick patients. Okay, this is the short list. There's like 12,000 bad things about positive pressure ventilation, okay? The good news for you is I only have an hour and a half, so this is the short list. It increases intrathoracic pressure. You're going to see how bad that is. It decreases venous return to the heart. You're going to see how bad that is. It decreases mean arterial pressure, which you should already know is bad for the brain in any sick patient, not just traumatic brain injury. It decreases cerebral blood flow. It decreases coronary blood flow. By the way, those are the two reasons why we do CPR. And we're ruining our CPR with positive pressure ventilation. That's why in Arizona you don't get intubated or bagged until 8 minutes now. We'll come back to that. You know, your compression-only CPR, that's the new thing out of Arizona. Let me show you how slow we are. In our pig lab at the University of Arizona 25 years ago, we knew that if you have a set of pigs that you induce VF in and they arrest, and if you do just chest compressions and you let them choke on their tongue on room air, that's your A and B, okay? Room air, no, not doing anything with the airway, not bagging, not breathing, for 10 minutes. And you just do good chest compressions, all of them live. The next day they're yes, you get tenured for doing neuro exams in pigs. The Arizona state dollars at work, tax dollars at work. They're all normal, happily eating. Don't even know what happened. And the next day, if you did, at that time, flawless ACLS, tube in, ventilator on, everything perfect, they all died. It took 15 years to have a medical director in the state of Arizona to find out that only 1 in 50 cardiac arrest patients in Arizona survived. This was 12 years ago. 2% survival in the state of Arizona. So Ben Bobrow realized we couldn't kill anybody else. Everybody's dying. So what we did was we translated the pig lab into the EMS system of the state of Arizona, and in the last 11 years we have quadrupled survival in the entire state. No place in the world has ever done anything like this. Because, guess what it is? We knew 25 years ago in the pig lab that it is, now you all know, of course, God said A, B, C. It's the one commandment in EMS, right? You go to EMS hell if you don't get A, B, C. Well, guess what? It's the CABs. They already have a lung full of air. When their heart stops like that, what do they need? They need to circulate the oxygen that's already in the bloodstream. Duh. So you're going to see a reversal tonight. But in any case, I want to show you, the reason why I went through that was to show you how we've been in the midst of questioning everything we do in the environment of the Arizona EMS system. And so everybody's in. 93% of the patients now that are cared for in the state of Arizona get minimally interrupted cardiac resuscitation, compression-only CPR. Nobody does even positive pressure ventilation, not even bag, until 4 cycles, 8 minutes of CPR without positive pressure ventilation, just high-flow passive oxygen. And it's been associated with a quadrupling of survival. Anyway, okay, so what's wrong with positive pressure ventilation? I want you to think about it this way. God made the cardiovascular system to work properly when air is being sucked, not pushed into the chest. Now think about this. Sorry, respiratory therapy, I'm going to blow up your entire science now. Because, think about this. Unless you've gone to the OR for a procedure, or unless you've had a really bad event, there's not a single breath in your life you have ever taken from all the way back to the first one that was pushed into your lungs. Not one. You come down the birth canal, this amazing thing happens. It gets really tight. The chest is squeezed. All the amniotic fluid is squeezed out of the chest. And what happens? All of a sudden, you get this huge explosive expansion of the chest when the baby is delivered. And the chest goes, and what's the baby do? And fills up with it. And every single breath, all of your life, has always been relative. It's not negative pressure, of course. There's still almost an atmosphere of pressure inside the lungs. But relative to the external, it is always, every single breath we ever take, and we are meant to take, is always sucking air, not having air pushed into us. Positive pressure ventilation is bad. So notice, the reversal of the negative pressure dynamics of ventilation messes almost everything up. So when we congratulate ourselves for the really nice ICUs, and everybody's sitting around on their ventilators, these beautiful new expensive ventilators, and have all these beautiful numbers and stuff, we're congratulating ourselves for messing almost everything up because we're using positive pressure ventilation. Now, right now we don't have a good alternative, but let me really shake you up. Positive pressure ventilators are a major downgrade from iron lungs. Now, none of you were alive. I wasn't even alive when the nation had tens of thousands of iron lungs for polio patients, right? And how did iron lungs keep polio patients alive? Actually, the right way. You're stuck inside of this iron lung, and what happens? The iron lung has a negative pressure, which then expands the chest so that they suck air in rather than having air pushed in. Now, the problem is we still haven't figured out how to create that iron lung dynamic and still be able to have access to do all the rest of the stuff, right? We still have to put in central lines, and we still need access to their arms and legs, and we need to be able to put in chest tubes. So the reality is, but if we could figure out a way, think about this, in the ideal world, endotracheal tubes would be used only for airway protection. Yeah, if they're comatose, you want a tube in to protect them from aspirating, but you know what? In the ideal world, we would not push air into that tube. There would be some way that we could create a relative negative pressure in the chest so that air would be sucked into the ET tube. Everything about positive pressure ventilation is actually bad for patients. It's better than dying, but in some cases. Notice, okay, so positive pressure ventilation is bad. And hyperventilation, so this is really bad for patients. This is too fast. Again, there's a gigantic list of what's so bad about hyperventilation, but let me just point out the two. First of all, it increases intrathoracic pressure. What happens when you increase intrathoracic pressure? It worsens all the negative effects of positive pressure, and as you know, it can lead, if you're going too fast, even if your tidal volume is normal, even if you're squeezing the right amount, you can end up stacking. This is even in non-COPD, non-asthma patients. You can end up stacking pressure upon pressure because you're spending so much time inspiring because you're going too fast. In fact, in some EMS systems, I'll show you some of the studies, some EMS systems, the average post-cardiac arrest, post-return of spontaneous circulation, intubation ventilation rate manual is over 40 a minute. If you are doing normal tidal volume at over 40 a minute, you are stacking pressure upon pressure, and it's really bad for patients. And, of course, going too fast, even if your tidal volume is normal, increases the minute ventilation. So just to remember back to whatever school you went to, the tidal volume is the amount of volume that you put into the lungs in one breath. That's the tidal volume. Minute volume is the total amount of volume that you do in a minute. So if you do the right tidal volume, but you double your rate, then you double the minute volume, and then, as you'll see in a minute, that dramatically decreases in CO2, which is really bad for all kinds of things, but especially the brain. Okay, overventilation is really bad. So overventilation this is a little bit streamlined. It can be more sophisticated than that, so don't run me out, respiratory therapists, because you know it can be a little more complex. But this is functionally what overventilation is. It is high tidal volume and or high airway pressures. And of course, those are often associated, but it's either of those. That's overventilation. It's too much air, or air too fast, or squeezing for too long, right? It's pressures, it's volumes that are too big. Hyperventilation, and again, technically there's some crossover, but hyperventilation is too fast. This is different. This is overventilation, and you're going to see it's a real eye-opener how important this is. Okay, so it's been shown over and over again, I've made it really clear, that basically what we do in the EMS and in the ED for resuscitation when we're doing manual ventilation is the absolute antithesis of lung protective ventilation. That'll certainly be meaningful to the critical care nurses, to some of the physicians, and to all the respiratory therapists, and we'll come back to the definition in a minute. But let me just point something out here. Let me do the FDA-approved kill switch here. Literally kill switch. Whoever made the big bag should be executed because they have killed so many patients. You know what this is? 1,800 cc's. This baby is 1,800 cc's. Aren't you glad when you get that tube in, you can really use that tube? Okay, so here is what has happened in Arizona. We're going to come back. We'll have a stretch break in a few minutes, and we'll come back, and we're actually going to work with the flow-controlled bag and more details on it. But what I just want to point out, the single thing I want to point out for the moment now is this, in the EPIC study in Arizona, this, 2 fingers, these 2 go away. Those 2 go away. This and 1 finger on this, and only for the 1 second, I love this manufacturer because this doesn't just flash every 6 seconds, 10 per minute, but it actually stays for a second. So you're only supposed to squeeze gently for as long as the light goes. So let me show you what a proper ventilation is with a human hand. Okay, you ready? Now, by the way, all of a sudden, some of you are already saying, wait a second, somebody time this. That delay, the manufacturer had to screw up. That can't possibly be every 6 seconds. Let me tell you, tongue-in-cheek, this is how we taught how to not hyperventilate in EMS. If you've gotten into the ambulance and you're transporting to the trauma center, and if you don't have them on your ventilator yet, then here's what you do. You gently give the squeeze when the light goes on. If you don't have the light, gently give the squeeze, and then ask the driver to stop the ambulance. You walk slowly around the ambulance, and then when you get back in and start the transport again, it's almost time to give the next. It's really hard to do it this slowly when our epi level is higher than the patient's, okay? In fact, it's impossible. I'll show you in a minute as I talk about IVI. But in any case, this is a proper ventilation with a manual bag, 2 fingers, and when the light goes on, and as soon as the light goes off, it goes away. You ready for this? 2/3 of a can of soda. 2/3 of, you know what? Do you know how many cans of soda you can put in here? Like 12, okay? It's ridiculous. So who has ever thought of using a bag like that? In fact, don't embarrass me if this isn't true in your experience, but I go into the ICU now at the University of Arizona. Who was here when we were all taught you give 10 cc's per kilo, or even 12, because man, we want to keep those alveoli open, right? 10 or 12 cc's per kilo is the tidal volume. Anybody besides me? There got to be some. That was it. You put the tube in and you give 10 to 12 cc's per kilo. And 12 may even be better because, again, we don't want any of those bazillions of alveoli. We don't want one of them closed. More on PEEP later, okay, for EMS at least. But think about this. Now today at the University of Arizona, we use in 95% of the patients. There are, of course, exceptions in specific conditions, but 5 cc's per kilo. Do you know when you walk through the ICU at the University of Arizona, if the patient's comatose, they look dead because the average adult, you cannot see the chest move. That's how gentle a lung protective, and I think about my whole career. Now, let me show you my career. I've been an attending physician for 32 years at the busiest trauma center between LA and Dallas. We do, ready for this? We do 10 trauma RSI intubations per 24 hours. Every 2.5 hours, we're putting somebody down and intubating them for trauma in our setting. That's how busy we are. And it's so busy that the early day arguments between the trauma surgeons and emergency medicine are long gone. We alternate back and forth. The trauma surgeons are almost now, can't you guys just run them? If they need to go to the OR, I'm so stinking tired, just call me. You guys run them. So we alternate back and forth. So I have run hundreds of intubated resuscitations in my career, and until about a decade ago, you know how I ran the resuscitation? If I was the one running it and I did the tube, sometimes often the resident's tube, but if I did the tube, I've now gotten the tube in, and you know what? I'm not going to let anybody touch that tube because I don't want anybody to mess with my tube because it's my tube. And, you know, okay, everybody, you know, everybody's saying, oh, you're amazing, right? By the way, paramedics, do not look smug. I know this is exactly like you too. Okay, so here you are, you're right, and this is how I'm running the resuscitation. Okay, now next we need to get anybody ever else done this, or am I the only one on the planet that has killed my patients? Okay, or at least their brains. Isn't this right? You're doing that and you're doing that. Why? Because 1, I thought the tube was like doing God's work. 2, it's amazing, and by the way, we cheat in emergency medicine because the paramedics, you don't get to charge for the tube. We do. Okay, so there's even another conflict of interest for putting that stinking tube in, right? And focusing on the procedure. The hospital gets to charge for ventilation. I don't get to charge for ventilation. Who cares about ventilation? So that's the whole career of all of us who are junkies for getting a tube in. And here we are, we're running the thing and we're doing this, and you know what? What we have done is we are stretching the alveoli. We'll come back to this in a minute. And we are setting all those patients up for acute respiratory distress syndrome. Again, more data on that in just a minute. But the reality is, those days have to be completely over. We're going to deal with how in the world do you do that in our kind of setting in just a minute. But okay, so that's the big bag thing. So here's the key: unless meticulously guarded against, emergency manual ventilation is reliably, and this is by any hands. I don't care if you're an anesthesiologist, a respiratory therapist, an RN, an MD, a paramedic, a basic EMT, in human hands during the fray of resuscitation, unless it's meticulously guarded against, every one of us give too forceful and too deep of a manual ventilation. Every last one of us. Okay? So 100% of emergency care providers have this specific, well-documented, and we are the ones that documented it, neuropsychiatric disorder. You all have this psychiatric disorder. You ready? And so do I, because I'm an emergency care provider. It's called inadvertent ventilatory inattentiveness. Okay, let that soak in for a minute. It's inadvertent. Like I said, it's second degree. It's not first degree murder. It's inadvertent. And we all are inattentive to doing this. All of us. Because the place is crazy. And you add on top of it, we're congratulating ourselves for the A. Okay, so notice, why do we all have IVI? Because we're too busy saving the patient's life and too proud of getting the tube in to pay any attention to something as trivial as the B. We're distracted. So here's the syndrome. During emergency manual ventilation without meticulous prevention, everyone hyperventilates and overventilates. We all go too fast, and we all push too hard and too long. Every last one of us. And the studies, I already mentioned this, some of the studies show the mean rate, forget the overventilation for a minute, is as high in some systems as 40 a minute. Okay, so why do we have IVI? Because distraction is inevitable. Because ventilation is remarkably gentle. I've already showed you. Do you know that what's a crack up to me is, back in the day when I was training, the ventilator took up half the room in the resuscitation suite, right? They were gigantic. And do you know what that gigantic thing did? It did that. That gigantic thing is really, really gentle. The human hand that's with a distracted mind is never gentle with it. So, as I said before, our adrenaline level is higher than the patient's. And here's the other thing. Proper ventilation just doesn't feel right. If I'm not moving their chest, the tube couldn't possibly be doing what it's supposed to. So, man, I'm going to move that chest, aren't you? I want to move that chest. Here's the beauty. Now that does everybody here in your practice setting have end-tidal CO2? Okay, yeah, I'm seeing like nods essentially everywhere. Okay, here's the key. You do not need to see the chest rise. In fact, if you're doing lung protective ventilation, you won't see the chest rise okay, if you've intubated a 9-year-old boy with 5% body fat, you'll see the chest rise probably. But the reality is, the beauty is you don't have to see the chest rise because you get to see every single exhalation that shows you that the tube is still in the right place. You don't have to see the chest going up and down to know that the tube is in the right place. In fact, what's one of the classic ways to know the tube is in the right place? Chest rise. Do you know what we were doing when we were checking for the tube? We were overventilating to make sure the chest rose. Isn't it amazing? We have built this all wrong. It's all backwards. Okay, so, by the way, Lars Wick, who's from Norway, world-famous resuscitologist, he's an anesthesiologist, and he was at one of the times I was giving this talk, and he said, Dan, of course anesthesiologists do this. We were born to ventilate. If we get that tube in, we're going to use that. Bag. So it's just kind of how we are. So here's the cure. Meticulous, multifaceted, active adjuncts to help prevent hyper and overventilation when you are manually ventilating, and to get you to markedly shorten the time that you manually ventilate and get patients to a ventilator. Let me just ask this question before we take a quick break and then come back and do some hands-on stuff. How many here have ventilators in the setting where you do emergency care? Raise your hands high. Okay, look around. Okay, so good. Almost all, and maybe all the EMS providers here, you have ventilators. And we'll come back to this in a moment, but at the break, I want to tell you this. Many people have said, I don't need all these things because we put them right on the ventilator. No, you don't. You don't put them right on the ventilator. And the reason why is, do you know how long it takes for the nerve cell to start dying when it has inadequate blood flow? And remember, you drop a little bit below, you drop to 32 on that CO2 and you already have markedly compromised blood flow to the brain. Do you know how long it takes for the neuron to start dying with inadequate blood flow? 4 minutes. When's the last time you went from the first breath after intubation to getting the patient on your ventilator? Probably never. So this is really important. Okay, so by the way, I'm in the state of Arizona. This is important enough in Arizona. We just approved end-tidal CO monitoring as a BLS skill in the state of Arizona, even though it's not in the national training or the national skills. And you'll see in a minute why we specifically want it to be the EMT. The EMTs, basic EMTs, you're going to love this. Get ready to elbow the paramedic next to you. You're going to love this, okay? But first, enough about that we understand this. Okay, so this is end-tidal CO2 monitoring reads backwards because it seems like, when it goes up, that should be when they're inspiring, right? And when it goes down, that should be when they're inhaling. It's not. So let me just explain it. The ET tube is in. and there's a sensor that picks up on CO2, right near the entrance to the tube, okay? And in the air, in the ambient air, there's essentially zero CO2. It's so tiny and minuscule it reads as zero, okay, to the sensor. So what happens is, let's start with an inspiration because it makes a lot of sense. You start pushing air or oxygen from the atmosphere or from an oxygen tank. You start putting that in, and the CO2 level that the sensor sees drops precipitously to zero, right? Because you're pushing no CO2 through. You're pushing through either 100% oxygen or air, or some combination, and air has functionally zero CO2, okay? So it very quickly drops to zero. And this is a proper ventilation here, okay? So notice, for 1 second, and only 1 second, it stays at zero because that was a proper ventilation that lasted 1 second. And then what happens is as soon as you let the pressure off, the patient starts to exhale. And notice what happens to the CO2 level. The CO2, which is in us right now, the concentration of CO2 in our alveoli, in our lungs, is 40 millimeters of mercury, okay? That's what's in our lungs. So as soon as you start exhaling past that sensor, very quickly it goes up, and then we won't talk about any other waveforms because it's not necessary for us to understand how to do this. And then for the rest of the 5 seconds, that interminably long 5 seconds for expiration that the patient really needs, okay? It slowly drifts up, and then the reason why you have heard the term end tidal CO2 is a tidal cycle in classic respiratory sciences is from the beginning of inspiration, through exhalation, all the way until the next inspiration starts. So it's the end of the tidal cycle, okay? So end tidal CO2, in this case, is exactly what it should be, 40, okay? That's the target, okay? And this doesn't matter what your patient is, that's your target. We'll ignore COPD for the moment, because it's almost inconsequential to what we're talking about today. Okay, so notice this. All right, so notice this. Even if the ventilation is really nice and soft and is the right tidal volume, let's say it's lung protective, it's just 2 fingers and it's just a little bit. But if you go, in this case, almost 3 times as fast, notice the pressures may be okay, although that fast, you're going to actually stack some pressures. So the pressure is going to go higher than it should. But notice when you're doing that, what you have done is, and what's different in addition to the rate, what's different about these waveforms? They only get up to 30. Remember what happens to sick patients when they only get up to 30? We kill their brain cells, okay? This is a disaster no matter what sick patient you're taking care of, okay? Bad. All right, I showed this in the extreme. This is where the expiration was basically a second, and then we went like all 5 seconds, okay? Now tell me that this wasn't too big of a ventilation. Okay, I showed it in the extreme, but you know what is typical in this setting? Remember, I'm running the trauma resuscitation. Typical is about half the time I'm inspiring and about half the time I'm expiring, right? It's about half and half. When I'm half and half like that, I am way stretching the alveoli, I'm way stacking, and I almost for sure have given way too much volume. It's just too long to push the thing for me to spend that much time. So too long is bad, and notice, of course, when you're doing too long, it's going to be, it may be way lower than 30. And then here is, let me notice this. You see this waveform? And see the waveform up here? They're identical except for one thing. What's different about this waveform and that waveform? Just the end tidal CO2. So, what does this, since the waveform is identical, what does this tell you about the tidal volume, the amount that's being given up here, and the amount that's being given during this second? They're both just inspiring for 1 second. They're doing the right amount of time. What does 30 mean is happening during this 1 second of inspiration? Too much. Everything else was right. You were following the timer, but the problem is you might have been using your whole hand. Okay, so notice, you can have everything perfect, but if you give too much with every inspiration, you get killer CO2. Okay? So, has anybody yet stumbled into the fact how far away we have been from this kind of care with this thing? It's really quite striking, isn't it? And this is what we added in Epic because we knew just the widgets wouldn't cut it. The VEMT, or the ventilator EMT, you'll see in a minute, it's a double entendre. And this is it. It's the most important person on the team. You now know why. Because the B should be gigantic and the A should be little. Here's now the time where you should gloat if you're a basic EMT. Let me tell you what your role is in EMS. It is to keep the paramedic from killing the patient with their advanced skills. Everybody got that? Yeah, I mean, the EMTs are going to go home feeling really good tonight. Paramedics, not so much. Okay, so this is true. If you're the intubator, somebody else needs to take over who cares about the B and does nothing but the B and never gets distracted. So think of this. They are protected from distraction. They're the most important person on the team. They only have one job. Here's their job. Constant vigilance on gentle, controlled, slow, small breaths, carefully following the ventilation rate timer and preventing any piston engagement, not one time, if we do it right. Constant attention to end-tidal CO2. 2, bothering everyone until the patient is on a vent. This person, the whole time, is supposed to be saying, why haven't you put them on the vent? Where's my vent? Why haven't, okay, in the resuscitation suite at the trauma center at the university, you know what we had to actually treat? Anesthesia doesn't come. We do all the airways, emergency medicine does. But we actually have dedicated RTs. We're so busy. And you know what we had to start doing with the RTs? We had to actually train them. No, you don't bag the patient up. No, you don't have to feel the lungs, because if you're feeling the lungs, you're pushing way too hard. So interestingly enough, you ready for this in our setting? Because remember, you no longer have any question if the tube is in the right place. With the very first exhalation, you know the tube is in the right place or not in the right place. You ready for this? There are tubes that go in, and the RT connects the ventilator for the first ventilation. That's the kind of meticulousness that it takes. So this person should be driving that. Okay, so in EMS and in the ED, until the patient's on a vent, every breath should be administered with ventilatory adjuncts by totally committed team member, with every breath being observed. You ready for this? About a year into the training with Epic, you know what we realized? The VEMT gets distracted. So in the state of Arizona, and I think, tell me, in any of your systems, do you only, big crash, bad injuries, do any of you only have 1 or 2 providers at the scene within, or do all of you have more than 2 providers within 10 minutes, say, of the crash? Is that true here? Because in Arizona, 95% of the cases have 5 EMS providers on average there within 7 minutes of the 911 call, okay? So, you know what that means when and 2 of them are intubators, right? 2 paramedics, 3 basic EMTs, typical. So what we now have done is we've added the watcher. And the watcher's role is this. They watch and wait for the VEMT to get distracted, and then they take a plastic baseball bat and hit him in the side of the head and say, you're supposed to be doing ventilation, don't care about the stupid IV, okay? So we actually, think of this. This is how hard it is to do. 2 dedicated people on the pit crew to make sure that every single manual ventilation is done correctly. That's how hard it is to do this.